Now we're going to get ready to hear from Dr. Andrea Silver. Dr. Andrea Silver is a medical oncologist who specializes in breast cancer care. She is the co-director of the Women's Center for Breast Health at the Hospital of St. Raphael in New Haven, Connecticut, and an associate professor of medicine at Yale Medical School. In addition to her clinical role as a breast oncologist, she directs the oncology clinic at the Father McGivney Cancer Center, which provides cancer care to the uninsured in New Haven. And I can attest that they are an excellent facility. Dr. Silver has a special interest in breast cancer in Black women. She has received national recognition from the American Cancer Society and Susan G. Komen Foundation for breast cancer programs dedicated to improving outcomes in underserved populations. Let us put our hands together and our spirits in a receptive mode as we prepare to hear from Dr. Andrea Silver.
Thank you so much for having me here today. It's a real honor to see all these women and to see all these healthy breast cancer survivors in this audience. And put your hands up for all of you being here and being here alive and willing to listen. My topic today is to talk about breast cancer in younger women, and as was mentioned, I have a particular interest in breast cancer in African American women. And these two topics belong together because breast cancer is more common in younger women in African American populations. Now, why is that? We'll talk a little bit about it, but let's first start out with what is the way that we have to make sure breast cancer is diagnosed early. Well, that's the mammogram. And the American Cancer Society and the National Cancer Institute have decided at the age of 40. How did we come up with that number? Well, we came up with that number because 10% of all breast cancers are seen in women less than the age of 40, and we want to capture the 90% that are above the age of 40. Well, that is not true for African American women, where you see a much larger group of women having breast cancer in their 30s. And the age that you would start screening, if you were looking in African American women, is age 33, not age 40. In other words, there are more than 10% of women who are between age 33 and 40 who do get breast cancer. Now, those are not the screening guidelines. And what do we do about it? What do we do about it as women here? Well, number one, do not let any doctor or health provider tell you or any other woman you know, because you are younger than 40, you cannot have breast cancer, or it must be a cyst. We know that 20% of breast cancers in Black women occur between the age of 30 and 40. So that is an age that when women feel something, they need to get attention, even if they are not getting a screening mammogram. So any lump that has not been investigated and doesn't go away needs to be investigated. I think there are people who are trying to push to change screening guidelines so we do better screening for women of color who are going to have those early breast cancers. Why do women get breast cancer at an earlier age? Well, that has to do with some of the risk factors. One of the things that happens in Black women is that they start to menstruate at a younger age, a little bit younger. And the longer the periods you have of having estrogen stimulation, and hey, all we women here know what estrogen stimulation is about. We all live with that, and we all live with the lack of that. So African American girls start menstruating a full half a year to a year before Caucasian girls. So that puts them at risk earlier. The other thing that people have started to look at in terms of research is that maybe because on an average, African American women start having babies at a younger age, and there's something about having babies that even though it's protective, it may also stimulate cancers that are there. There's a longer period of having babies that are seen in African American populations. So that's one thought. But the bottom line is, do we really know the answer? We don't know the answer, but we do know, unfortunately, some bad statistics. And that's that even though mortality in breast cancer has declined in white women, black women haven't seen that decline. And people have looked at reasons, even in a state like Connecticut, where we have many, many women getting mammograms, and the percentage of women in the state of Connecticut who have had mammograms, it's about 80%. But still, we are seeing black women diagnosed with larger tumors, more aggressive tumors, and at later stages. Now, why is that? And when I say more aggressive tumors, I'd like to stop here and talk about what makes a tumor bad, what makes a tumor aggressive. Why are there some women who manage to just get a lumpectomy and radiation and maybe take a pill? And why are there other women who are on chemotherapy, need a mastectomy and radiation? Some women even need double mastectomies. Why is that? Well, there are things that determine what makes a breast cancer easy to handle, and one is something called hormone receptors. And anyone in this audience know about hormone receptors, estrogen receptor positive tumors, progesterone receptor positive tumors? Well, that just means that this tumor was stimulated by hormones, either ones you've taken or hormones that are produced by your body or by your ovaries. In the general population, 70% of women who have breast cancer have hormone receptor positive tumors. In black women, it's about 40%. Now that's a big difference. When tumors are not sensitive to hormones, it makes them more aggressive, and it also means that you can't use the common pills that we use to treat breast cancer, like tamoxifen or some of the other drugs that are called aromatase inhibitors that are available for postmenopausal women. So this is something that we know is different. Why is that? Well, some of it may have to do with the fact that the younger women are more likely to have hormone receptor negative tumors, but the bottom line is women who have hormone receptor negative tumors have to have chemotherapy. And the growth rate of the tumor is more aggressive, so that makes tumors larger, and it makes tumors more likely to have positive lymph nodes. And these are all things that may make the outcome worse. So I hear women saying, and I don't know if anyone's heard that term, triple negative breast cancer. Are there women here who've heard that term, TNC? Okay. Well, you know, when people talk about triple negative breast cancer, they sort of say it's a bad kind of breast cancer. That is partially true, but it's not completely true. I've had women come into my office and say, well, I have that triple negative breast cancer, and I hear that's the bad kind of breast cancer that black women have, and that it can't be helped. Untrue. That kind of cancer does respond to chemotherapy, and chemotherapy can help make sure that woman is cured of her breast cancer, but chemotherapy has to be delivered, and it has to be delivered in a timely fashion, and it has to be delivered with full doses. And one thing, when you look at black women, they're much less likely to get that full dose of chemotherapy, or chemotherapy within a certain period of time. Chemotherapy really should be given within 8 weeks after the diagnosis. Sometimes I'll see women, they've been going to the clinic, couldn't get in to see a doctor. It may be close to 3 months, 4 months, and they haven't had their chemotherapy yet. even if the chemotherapy is given, it's had that period of time for the cells that are circulating in the bloodstream to multiply. And that's a bad thing. So it's really important, if someone has a diagnosis, to get treated in a timely fashion. Well, what does that take? It takes good doctors and it takes health insurance. It takes some sort of support. And one thing that I see particularly in New Haven, who are least likely to have insurance? Well, it's the young women. They may not have jobs that provide them benefits, and I sort of call them the pink-collar jobs. And sometimes when I give this talk, someone says, what are you talking about, the pink-collar jobs? I don't know about the pink-collar jobs, the women who may be taking care of my children, women who may be taking care of your aging parent who's in the hospital. These are jobs that are incredibly important, but don't have any benefits with them. And that's a sad thing to say about our society, that you can have people who are taking care of children or taking care of the elderly, and not to be, sort of really blunt here, but the people who I say are bathing your mother in a nursing home, who are washing her and combing her hair, may not be given health insurance. So if they're not given health insurance, it's going to take a certain amount of time till they get their treatment. And it's really essential with young women who feel a breast mass, and I'm talking to some of the young women in this audience here, to advocate for yourself. You do have some power. There are doctors in New Haven who want to see you. And if you see someone and they say, well, you are 30 years old and it is unlikely that that is anything more than a cyst, so don't worry about it. I say no one can lay their hands on you and tell you what's going on beneath your skin. That doesn't make sense. I mean, I've had a fellowship. I can't do it. You cannot tell. So if someone's saying that to you without scheduling you for a follow-up appointment or scheduling you for a scan, unless they have superpowers, they're not giving you the full degree of care. Yes, sometimes you can feel something and it feels really hard and you know what it is, but the other person who has something that isn't normal, but it's not definitely cancer by exam, you've got to go further. And where I say to empower yourself is if someone doesn't want to take you further or tries to put it on you, well, maybe you should go home and let us know in a couple months how it's doing. That's not good enough. It's incumbent on that health provider to have a good idea. And one way you can say is, well, if you don't think it's cancer, what do you think it is? If they don't have a good answer, say, well, how are we going to figure out what it is? It's really important that women take that responsibility for themselves. Now, what are the risk factors for breast cancer? Dawn talked a little bit about it. I'm sorry to say, but one of the risk factors for having breast cancer is being female. And even being male doesn't let you off the hook. So anyone who has breasts can get breast cancer. So when people say, well, it's not in my family, or sometimes I've even had people say, well, I thought breast cancer is a white woman's disease. It's just not true. Anyone can get breast cancer, and that means some of the risk factors that we talk about, someone who doesn't have a baby till they're over 30, or someone who has few babies, or someone who has a family member with breast cancer. Yes, they may increase your risk of breast cancer, but it doesn't let anyone off the hook for saying not having it. Now, what are other things we can do to help change that, what I call, and what everyone calls, a health disparity? A health disparity is a difference in outcome due to either a race or due to someone's different circumstances, either ethnicity or socioeconomic, that one group of people doesn't do as well statistically as another group of people. Well, one thing that they've noticed, and I did say that African American women don't get as much chemotherapy given to them. And part of that, it may be due to delay, or it may be due to some places where they're not treating women optimally. But you look at a place like New Haven, there are hospitals, there are oncologists. We're not talking about rural Alabama. We're talking about something where women can get to medical centers. But one thing that I notice is sometimes African American women have not had good health care from the get-go. And that is as simple as things, and we're talking about young women here, dental care. You might say, what does dental care have to do with breast cancer? Well, if someone comes in with bad teeth, when you give them chemotherapy, they're more likely to get an infection. And if they get an infection, you're going to have to delay their next chemotherapy dose. So even if the patient and the doctor are all gung-ho, all on board, they're not getting as much as they should get. And that is a problem. Or let's take other health problems that you really see a lot of in African American communities. Diabetes. Diabetes and hypertension. Again, you might say, well, what does that have to do with breast cancer? The number one disease that really influences the outcome of breast cancer as a comorbidity, in other words, a disease that doesn't cause breast cancer but may affect its outcome, is hypertension. Well, when I first heard about this was a shock to me, because I said, well, I'm not quite clear how hypertension would really affect what happens with breast cancer. But then I thought about it more. Well, one of the drugs that some of you women may have had is a drug called adriamycin. That's a pretty classic drug that they give women with breast cancer. Well, you have to have a completely normal heart to get the amount of adriamycin you need. And if you have hypertension, the test that we may do may say, well, you can't get adriamycin. So that does affect things. Another thing, hypertension, what it may do is deplete you of your potassium. So some of the other drugs we may use, we can't give them, or we have to hold them. Or even things like volume changes may change the amount of dose of chemotherapy we give. And then I'm going to get to another thing, which may sound like a funny thing. But as women, and I'm a woman, and I believe all women are beautiful. But just keep in mind that a lot of the breast cancer studies were done on, as I call them, the healthy, the wealthy. And the healthy and the wealthy, some of them, and I've looked at these studies, some of them are smaller, they're thinner, they have better education. The mammogram studies were basically done in Sweden. Well, I'm looking at all you women here. Anyone in this audience Swedish? It may not apply. It may not apply to the women who are here. And you might say, well, why am I saying that? It doesn't have to do with the color of someone's skin, but in Sweden, the average age that girls menstruate is age 16. That's not what we see in our population in New Haven. If you're talking about the average size or the average weight being around 140, that's not what we see in our population in New Haven. Why would that make a difference? Well, if all the dosing is based on those size, we may be dosing someone differently. And I can tell you, in my clinic, I took care once of a gentleman, lovely, lovely guy, 400 pounds. And he, big guy, wonderful guy, but a big guy. And when I looked at every single paper, I could not see anyone included, African American gentleman, I could not see anyone included in any of the studies that looked like him, that weighed as much as him, that was his age, that was representative of him. And I said, I'm making a judgment based on people who are not like this guy, and how do I know I'm doing the right thing? So that is also a plea from me. It's really important for people to share their experience, to participate in studies, to show your face to the United States government and to health providers, and make sure that everyone is included in studies and in recommendations. Because if all we're looking at is the healthy, the wealthy, and the educated, all our treatments are going to be based on those people. And I've had so much trouble, for example, trying to get women who are not wealthy into clinical trials. It is probably, sometimes I joke, I say it is easier to get someone into an Ivy League college than to get someone into a clinical trial at an Ivy League college. And why is that? Well, they'll say stuff like, oh, the study's free, but you need to give cash up front for the professional fee. Or can you send someone from your clinic down to New York and can her family come and stay with her? Hello? That's not something that people who don't have a lot of money can do. So it's really important that everyone here becomes an advocate and an activist, and may I say this, a community organizer, and organize your communities behind making sure that healthcare is representative of you and your family and is not only representative of one population. Because I do not think that this is a problem that cannot be solved. And some of my concern is, and this is just an editorial comment here, that some of my concern by looking at biologic differences in African American women is ignoring the truth that some of what we're just seeing is poor health care and exclusion from a health care system. And it sounds so much more exotic and so much sexier to say, oh, this is a different disease. Some of what we're seeing is a disease of exclusion from a medical system that needs to be more in this country. But the things that I can advise for young women is to start out getting the best health care you can. And that means girls, best dental care, if you have hypertension, to treat hypertension, to try to avoid getting things like diabetes, because diabetes, any disease that you have, diabetes makes it worse. When women are having chemotherapy, they get steroids with their chemotherapy to prevent nausea. Well, the steroid sends the diabetes off the wall. So then you have to deal with the diabetes. These are all things, and I'm sure people in this audience say, I remember that happening with my family. All of a sudden her sugar went, wild, and she couldn't get her chemotherapy. So while there are people in the laboratory looking at why black women are more likely to get triple negative breast cancer, that's not the whole story. And I know Otis Brawley, who used to be in charge of minority affairs at the National Cancer Institute, NIH, and is now our president for the American Cancer Society, absolutely feels that yes, that's a part of it, but it's a very, very small part of it. And let's not look at the part that we cannot help. The part that we can help is advocating better medical care, diagnosing breast cancer at an early point, not ignoring the fact that younger women need to be diagnosed, making sure people get chemotherapy in a timely fashion, trying to make sure that the things that are given with chemotherapy to get full doses are available to people who may not have good insurance. There's a drug called Neupogen or Neulasta, which I think some of the women in this audience may have had. It's a drug that brings someone's white count up to a normal level after they've had chemotherapy. If they don't get that drug, it's unlikely that they will get their next dose of chemotherapy on time. Well, that factor can change the outcome with chemotherapy by about 25%. How much is that drug? Well, at the lowest price, it's $1,000 a pop. Some of the drugs, for example, one of the drugs that Rose may talk about, which is Herceptin, which is a drug that's given for HER2-positive breast cancer. What's HER2 positive? Well, I talk about HER2 positive breast cancer as being the breast cancer where a drunken carjacker has taken over that tumor and is driving that tumor. And there's a drug called Herceptin that can take that drunken carjacker out of the tumor. Well, that drug is unbelievably expensive. You need it for a year. And HER2 positive breast cancer is also more common in women of color. A full year of Herceptin, if you give the Neupogen and the chemotherapy, you're talking about over $50,000 worth of health care. And I've seen women who may have their health care paid for, but then they may not be able to afford to take their medications for hypertension, or they may be cutting back on those things. Those are all things that make a difference. And let's just get back briefly to family history. It's really important that Black women share their family history, because I think traditionally there have been women who have said, let's not talk about the cancers in our family. And sometimes I see people who don't even know what their family members had, or they say, I know that my grandmother had some female kind of cancer, but I'm not sure what it is. And to do genetic testing, which is a blood test, which can be very helpful, because women that have mutations in one of the two genes that we can test for, the genes are normal. Like when someone says, do I have the gene? We all have that gene, and that's a good gene. It's when it's mutated, it's the bad gene then. So when women have mutations, it's really important to know, because those women are going to need their ovaries out, and they're going to need MRIs instead of mammograms, or in addition to mammograms. But if someone doesn't know they have a family history, they're not going to be able to tell their oncologist that maybe they should be tested. And once again, Black women weren't really in the studies that had initially looked for what genes are active. So there may be mutations in Black women that we don't even know about. And when I say Black women, there have been attempts to look at whether this is just African Americans or West Indians or Africans. And the interesting thing that a lot of scientists have discovered is that you see some of the same things in populations, no matter where they came from, no matter how intermarried they are. You'll see some of the same mutations, but there may be mutations that we haven't even looked at yet. So my advice to you is to empower yourself, empower your daughters, make sure they get the best health care. Diet. I think diet is important, to eat a healthy diet, to exercise, to try to avoid obesity, which will reduce your risk of diabetes and hypertension. Make sure you get the care you need, and on a national level, advocate, and on a local level, advocate. And hopefully the next time I get to come here, and I hope I do get to come here again, there will not be that health disparity, and I'll be here saying that we're seeing all Americans, and not only Americans, all of the world benefiting from what we've learned about breast cancer. Because when I teach the doctors in training, I say we got to look at oncology differently now. It's not just treating a tumor. It is a tumor in a woman who is in a woman from a community, who is a woman from a country, who is a woman who is a participant of the world. And we have to think of cancer not just as an individual abnormal cell. We've got to think of all our health. Because when a woman has breast cancer, her family is affected, her community is affected, and when her community is affected, her state is affected, her country is affected, and it does affect the world. So I think of it as a problem that needs to be approached that way. I think I'm going to stop here. I don't know if we have any time for questions, but thank you so much for having me. It's a true honor.
If anyone has questions, my email address, or you can call me or ask me. I'm open for anyone that can call me.
Thank you so much, Andrea.